Hello everybody, here we are again. We're about to start unit number 4, the first one of the group in unit number 4. Again, this is week 1 of our 4-week class, and we're going to go over drugs of abuse. I hope you got your PowerPoints out already so we can kind of go through this. Shouldn't take too long, so hope you enjoy it. Our objectives for this unit, of course, this is chapter 9 in the 7th edition of the book, but I know somebody told me that they had the earlier one, and I believe on that one it is chapter number 8. The objectives of this one is to explain drug dependence, both the psychological issues of it and the physiological issues of it. We also define some terms related to drug dependency. And some of those are the understanding of knowing that interchangeably the word drug, substance, chemical is all used interchangeably. It's basically talking about the same thing in all of those. Misuse, on the other hand, is another word you'll hear, either drug misuse or substance misuse. Generally, that is indiscriminate or recreational use of a drug or a substance for a purpose other than which it was intended to be. And that's like a lot of the different drugs you'll see that are abused that were actually had intentions to do something good that are being used for either recreational use or just other purposes. Drug abuse, substance abuse, those are culturally defined. These are things that it might be different in the medical setting or in a social setting than in the different cultures. And we'll talk a little bit more about that here soon. Addiction, on the other hand, is a complex disease of the central nervous system that causes a compulsive, uncontrollable craving. And these cravings eventually lead to dependence on a substance to this amount that if you take that substance away and deny that person that substance, then that they start having severe emotional, mental, and psychological dependency or results from that. And that is a dependence. As we go through this, we're also going to talk about tolerance, detoxification, and withdrawal, and ultimately abstinence for these people. Let's talk a little bit about cultural considerations. On the cultural considerations, that is always you have to think about it in the context of drug abuse, and that's what we're talking about here. So some of the cultural considerations you have to think about is the influence of this is defined by the perception of that culture. So some cultures may think of drug abuse as one way, and others may think of it as acceptable use. An example of that is in the Muslim communities. Any alcohol or substance, anything that causes mind-altering state would be considered abuse. And many conservative religious groups right here in the United States would also feel the same way. And compare that to many of the European cultures where alcohol is expected and is present at all family and social gatherings. So it just depends on where you are and who you're around at the time and what they think of that is which is abuse and which is just a normal behavior. And one way you can think about that too is the times that have changed over here in our own American culture here. Earlier in our time, cigarettes were glamorized, and it was even physicians, they were on commercials touting the good things that come from cigarettes. And now, from the research that's been done and the outcomes of people's lives and all with cigarettes, we are now much less socially acceptable of cigarettes. That they are probably less acceptable even than moderate alcohol use within our community. So that's just an example that could show you how the different cultures can also change over time. Some of the other definitions we want to talk about is that current research shows that the most addicting drugs increase the ability of the dopamine, and this is how they think it works, is that the most addictive drugs, as they increase the availability of dopamine and other neurotransmitters in the brain, then it stirs up the brain reward system, or the pleasure center within the brain. Inside the reward system there in the brain, you have a mesolimbic system, and that's where the reward pathway is. That's where you have mood elevation and euphoria whenever you're doing these substances. This is where the dopamine's effect takes place. That's where it gets turned on. And these cause strong motivations that lead to repeating the use of this drug or this substance again, which then leads to the addiction. And it's all trying to chase that mood elevation and that euphoria. And all this leads to the craving, the drug craving. And one type of the craving is called Q. It's Q-induced craving. What happens there is it occurs in the presence of people or places or things that previously are associated with that drug use or that alcohol use, that type of thing, any of them substances. And this can occur long after a person has been abstinent for a long time. And suddenly they get these cue-induced cravings. They'll be around a group of people or that they did these things with before. And it is also a common cause of relapse within the abstinent patient. So now we'll talk a little bit about the addictive states on your next slide there. Intoxication, that's a state of being influenced or affected by a drug or a toxin. And intoxication, this could be just a very small amount, especially in a drug naive person, or it can be a potentially lethal amount for the chronic user. Either way, intoxication, they are in a toxic effect. It's signs and symptoms of a toxic event. Detoxification, on the other hand, is the treatment for an individual who is intoxicated to remove or diminish the effects. To do this, we have to administer antagonistic drugs. We have to try to promote metabolism and elimination of the toxin that's causing this, that has intoxicated them in the first place. It requires intensive supportive care, and this is usually until it's naturally eliminated, because there's not a lot of drugs you can give. Mostly it's all supportive. The withdrawal syndrome, that is a group of signs and symptoms that occurs in a physically dependent person when a drug is stopped. Sorry, my screen flicked out there. Anyways, when you have drugs that are like your opiates, your alcohol, your barbiturates, any anoxylics, those are strong, physically dependent substances, and they have very strong withdrawal symptoms. So anytime you're around anything like that, those are the ones that you'll see most likely. They'll have to have intensive care to support their systems as they withdraw from those. And a lot of times that's the ones you'll see in the ICUs at the hospitals as they go through detox. The next group there, cannabinoids, amphetamines, these are a weaker dependence, and the withdrawal symptoms of those are also weaker. Treatment is slow weaning on most of these. Uses of cross-tolerant drugs helps. And basically all that is doing is you're just trying to control the symptoms and do supportive care to support them through this detox time. Cessation and maintaining that abstinence is the goal for these people. And there are drugs that you can use to help decrease the cravings of them. There's a few that you can use to help prevent withdrawal symptoms, to help maintain that abstinence. All of it is helped by cognitive behavioral therapies. That's recommended in any of these detox, especially for the rehab portion of it. And it really helps to get them all go a long way. And it has to be long term. It can't be just a quick fix. It's something they have to work on probably forever. Let's talk a little bit about stimulants. Some of the stimulants there are, the main one that everybody seems to know about is nicotine. Nicotine is the alkaloid that's in the tobacco plant itself. That nicotine is not the one that causes the dependence. The nicotine is not, I'm sorry, the nicotine is the cause of the dependence. It's what keeps bringing them back. Smoke alone contains 4,000 chemicals and gases in one cigarette. Including in those are 45 that are already known to cause cancer or at least tumors within that cigarettes. There's also a number of solvents, and the one thing to know about it is nicotine does not cause cancer. It's just the additive substance that's put in there that causes you to want to continue to smoke. Pharmacokinetics, it's rapidly absorbed into the blood through the lungs while smoking. That's the smoking part. If you chew and you put it in your buccal mucosa, basically that's a slower absorption, but it's a very fast absorption within the skin itself, so that it gets in there, but then to get through the rest of the systemic system, it takes a little while. And also the people who snuff tobacco, it comes through the nasal mucosa also a little bit slower. Nicotine crosses membranes very easily, and it's widely distributed. It passes easily through breast milk and into the infant, so that's something to be aware of. It's very low plasma protein binding. It's metabolized in the liver, and it's eliminated in the urine. Half-life on that is generally 1 to 2 hours. The effects of this drug, let's go back. Pharmacodynamics, I didn't talk about that. In the central nervous system, nicotine rapidly acts on that reward system in the brain that we talked about, releasing dopamine. It mimics cocaine in some of its effect, and it is a very highly addictive substance. The effects you'll see is all in the stimulation part. It's an increased heart rate, an increased myocardial oxygen consumption. There's an increased activity taking place in the CNS system. You have an increased respiratory rate, you have increased tremors, and you have a feeling of increased alertness and arousal, which is the opposite of what a lot of people will do. Is they want to smoke to promote relaxation and relief of anxiety. And when you get that is actually on the downward side of the cigarette smoking, and so then you're all relaxed and all. It's because the half-life's kind of gone past, and then the cravings will come back again after that goes by. You also have an increase in GI secretions. Withdrawal with cigarettes, or nicotine, just nicotine in general, withdrawal from that is usually started to fill within the first 24 to 48 hours. So there's several products out there to help with nicotine withdrawal, and that's using some of the nicotine replacement agents. And there's several drugs available in that there's the gum, the lozenges, patches, inhalers, the nasal sprays. Those are drugs that are the replacement agents, and what you do is you get smaller and smaller doses until you're able to get off of it completely. There's also Wellbutrin, which is bupropion. Say that fast. Anyways, that's one of the drugs. It's an antidepressant that has been FDA approved to help relieve some of the cravings that are taking place. There's also Chantix, and that's one of the big ones that is out there. It helps, and the generic name for that is varenicline. It's Chantix. It decreases the cravings, and it decreases the pleasure center and kind of holds that up. There's a lot of side effects with that, and it's hard to keep people on it. It works for a lot of people, individuals, but there's also some side effects, and one of those is some people have nightmares on that, and that's been documented that's something you need to report to your healthcare provider if you are experiencing anything like that. Another stimulant is cocaine. This is one of the most potent of the abused stimulants. It originally was made from the cocoa leaves of plants, but now it has been prepared synthetically. It is a Schedule II drug with the Controlled Substance Act. There are medical purposes for it. but it has become one of the major abused drugs that is out there too. Illicit cocaine is generally in a white powder. This cocaine is a cocaine hydrochloride. It is snorted, but it also comes in some other forms. There's a cocaine base, and that is free-based, which is either IV form or orally. And then there's also the crystalline substance that can be made from this, and that's crack. That is less expensive, and it's generally smoked. It's more readily available to the public. The peak blood levels on that is 5 to 30 minutes, depending on the route that it's ingested. Metabolizes again in the liver with a half-life of 50 to 80 minutes, depending on the route. Tolerance occurs in long-term uses, and in long-term uses on cocaine, it's not very long. You never get the same high you got the first time, and they chase that high continuously. Long-term users also become more sensitive to anesthesias and convulsives, that they can start getting into convulsions much quicker the longer they use it. And also that's something that needs to be aware of by the physician or the healthcare provider if they're going to have any anesthetics for a procedure or for a surgery. Again, this works on that brain rewards system, so that's where the problems arise. Another stimulant to be aware of is your amphetamines. These are also a Schedule II synthetic. It's a prescribed drug, but the abusers know this as the poor man's cocaine. The amphetamines, the PO use, there's usually peak in 60 to 90 minutes. The effects of them usually last 2 to 4 hours. There's very similar in their pharmacodynamics of cocaine, very much alike that. The effects of that, depending on if you smoke it, snort it, you IV inject it, all of those are more rapid results. Effects of that is your irritability, the anxiety, paranoia, and you can in fact get to seizures and death with using of it, the abusing. Again, it affects the brain reward center. It produces a euphoria. And treatment for people who are abusing this medication, generally speaking, they seek treatment for complications of the abuse, things like the panic attack or psychosis or depression. This medication, it is eliminated. As they're trying to come off of it, it's like an emergency management, the same as it would be for overdosing on cocaine. You're controlling high hypertension, tachycardia, and you're controlling this with your vasodilators and your adrenergic beta blockers. Elimination, you can enhance it with ammonium chloride just to acidify the urine and help it get out of the body faster. Amphetamines actually have a therapeutic use as CNS stimulants, but abuse by this is increasing doses, and then they start getting into using the methamphetamine crank or the methamphetamine crystals, which is your crystal meth. Caffeine is also a stimulant. It's the most widely used psychoactive substance in the world for getting stimulated. It's absorbed through the GI tract, and it peaks in about an hour. It also stimulates the CNS, especially in the medullary respiratory center. It has a diuretic effect to it, and it also has a myocardial stimulant effect. It relaxes smooth muscles. It promotes a vasodilation and a cerebral vasoconstriction. The effects of that is that it promotes alertness and it alleviates fatigue. That's why we have our cup of joe in the morning. The treatment for withdrawal is, well, you'll start having a headache, irritability, the drowsiness, and the fatigue. And the best way to deal with that then is we deal with it symptomatically and treat the symptoms as they occur. All right, let's talk a little bit about depressants. Depressants actually depress respiratory rate, they depress the cardiac rates, They depress your central nervous system functions, and it's widely recognized for abuse potential that leads to rapid tolerance, dependence, and medical emergencies due to overdose and withdrawal. And one of your most widely consumed substances of abuse is alcohol. This can lead to dependence with significant health, social, legal, and interpersonal problems. The effects of chronic alcohol abuse are numerous on all different parts of your body. One of the withdrawal symptoms that can be prevented is Wernicke's encephalopathy. Wernicke's is an inflammatory hemorrhagic degeneration condition of the brain, and it's due to a deficiency of thiamine. And this is due to malnutrition. Chronic alcoholics don't tend to eat well, and so they don't get thiamine through their food. And if it goes untreated, if they get to the point where this is developed and they're now having encephalopathy and they're not very coherent, if you don't treat that, then they will then go to Korsakoff's psychosis. And that is, you can't change it back. This is a form of amnesia that happens in the chronic alcoholic, and they lose short-term memory, and they suddenly have an inability to learn anything. So that would be a bad thing to end up in that situation. The drug therapy for alcohol withdrawal is, if you have a sudden withdrawal with chronic abuse, they can have life-threatening effects. Suspect withdrawal if any individual reports that they usually drink 10 drinks a day for at least the last 2 weeks, because then you're going to start seeing some gross tumors, seizures, tremors, hallucinations, delirium, and these we have to treat. You can look on your table too. There's a table on 9-7 that I was looking at, or on the newer book it's 8.2 or 8-2. Treatment for alcohol withdrawal is basically you start with your ABCs. You have to watch your airway, your breathing, and your circulatory system. There's really no antidote. You cannot give any stimulants to counteract the depression, but you have to watch out for hypotension. That is one of the things that you will see. So you treat that with vasoconstrictors. You can use gastric lavage if it's just been recently ingested and they can get it out of the stomach. If not, and it's very high amounts, they can then give dialysis and help get it through the blood. But mostly you're just treating the symptoms and trying to get some control over things that way. On all alcoholics, if there's anyone that comes in detox in any way, or even if they've come into the hospital for a surgery or anything else and they have been an alcoholic or drink a lot, we start them on thiamine IV or PO if they're able, 100 milligrams a day, just to prevent that Wernicke's encephalopathy from developing. You also want to watch their blood glucose. It's generally going to be on the low side, and you'll need to treat it. And then you work on getting them through that. Then you get them to go to rehab, and then there are some drugs that can be used to help with that. Antabuse is one of them. It takes away the pleasure and actually can make you feel nauseated and sick if you actually use it. So there are things out there to help them when they get to the rehab stage. One of the other depressants is opioids. This also acts the brain reward system. They used to be naturally occurring from the opium plant, but now there are many synthetic and semi-synthetic drugs out there that do this. Usually, if you take it through an IV route, the onset of the relief or the use of that drug is within seconds. Opiates are used on many things, pain relief within the hospital, different medications for different things. Morphine is an example of that. Treatment for overdose is naloxone or Narcan. This one is we use it a lot for anybody that we suspect may be having an opiate or overdose. This has to be used along with life support systems. So first thing you would do is make sure that your ABCs are in place, your airway, your breathing, your circulatory system. You give your Narcan, and a lot of times within minutes you'll see a total reversal of the sedative effects of the opioid, and the patient will come awake. The thing about Narcan, it also has a half-life just like everything else, and a lot of times Narcan's half-life is shorter than the opiate that they have now taken. So the opiate is still be in their systems. You've given the Narcan, they're feeling pretty much better. They're awake and breathing and talking to you now, but you have to remember the half-life is shorter. So pay attention to your patient, because that opiate will still be in there. The Narcan will wear off, and now they're already sedated again. Maybe they're not breathing again. So you need to pay attention to that. Then they need another dose of Narcan. But Narcan is a drug that we use with opiates. Withdrawal symptoms can also be treated if there have been long-term chronic abuse with methadone or with clonidine, are two of the drugs. Methadone is one of the major ones we use. The methadone, you give that in just decreasing doses over a period of days, and that helps detox. The clonidine, it also helps in the withdrawal symptoms, but it doesn't decrease the craving, so they're going to need help with that. Another opiate antagonist, this one actually blocks the euphoria, is naltrexone, and that just makes it so it doesn't give them the euphoria feel. A couple of good tables to refer to in the old book was the 8.7, but in the new one, uses for analgesia G6 is on 9-2, which is a good one, and drug interactions on 9-4. Some of the other drugs of abuse is cannabis, marijuana, hashish. It's the THC is the active ingredient, and that causes the psychoactive effects of cannabis. There's also inhalants. And inhalants are a drug of abuse by a lot of your pre-adolescents and adolescents, using it by snuffing or huffing, bagging, or spraying is some of the ways. And they use these volatile solvents and aerosols, and they use these, but there's a lot of things that can happen. Sudden death is one of them that does occur. They can, if just nothing else, pass out, and when they've passed out, they could aspirate GI contents, and now they've got aspiration pneumonia. They can have a trauma where they have fallen and hit their head up against the side of a brick wall. Also suffocation, as they use some of these things to get this inhaled into their body. Unfortunately, there's no antidote for these, and the treatment is totally symptomatic, so it's a matter of getting the person to the right place of treatment as soon as possible. The next slide is some of the special needs of drug abusing clients, the surgical needs of these patients. These are the patients like this. There's things that have to be thought of, like we talked about on another earlier slide. Surgical clients, when you're trying to treat them, you're going to get them ready for surgery. They need a higher level generally of medication, even to give them anesthesia, to give them pain relief. We have to think about all that. It a lot of times will take more of a medication for them to make an effect, simply because they have so built up a tolerance to the drug. So that does become a problem. Pain management. When they're there for a procedure or for surgery, or they've had some illness, that is not the time. We're not doing addictive therapy at that time. That's not the priority. Right then we're taking care of the patient's pain and their needs that way. Later on, then we can develop a written agreement with the patient, and then make a plan of how we're going to treat their addiction. So they're two separate things. We can't take care of both of them at the time, and the pain needs and the surgical needs are the first to come. Now we need to talk a little bit about chemical impairment of the nerves. I mean, it's unfortunately occurs more than we like it to be thinking of. It's a serious concern with 10 to 20% of nursing having substance abuse problems. And if you look at the numbers, that's approximately 300 to 600,000 nurses. So that's a big portion of us out there. 3 to 6% demonstrate impaired practice because of these drugs. Alcohol is the most common drug of choice or chemical of choice. Others like the Demerol, the Percodan, Valium, and Xanax tend to be drugs of choice for the nursing population. Factors contributing to that is that nurses have chronic fatigue. They become ill because of this. They have a strong responsibility they feel for their clients. They have different responses to illness and dying that may cause more added stress. Job dissatisfaction is another one. Nurses, you know, they have access to medications and chemicals. They may be having marital and child problems. Downsizing of these hospitals also causes an added stressor. Nurses may have a false belief in the drug that it might help ease some of their pain, of their stress and all. And they also feel like they have the knowledge about the drug, so therefore they can prevent the drug problems. The management of this situation depends on the state in which you're practicing. Some states, it's automatic withdrawal or revocation of your license. And in many states where the American Nursing Association and the National Student Nursing Association, they have been, and others, there's other advocates out there that have looked for alternatives to discipline. There's things that have been set up like diversion programs. They're monitored recovery programs with peer assistance programs. There's your employee assistance programs within the hospitals and the places of work. The goal of these is to provide public safety, which still is the #1 concern, and maintain integrity within the profession. They're providing a possibility of treatment before the license is revoked and help through rehab and hopefully keep that nurse to be able to work and maintain a lifestyle afterwards. Okay, so let's get to the practice questions. Your client has stopped smoking cold turkey after 2 years of smoking 1 pack per day and calls for a clinic appointment. He asks to see you. His signs of nicotine withdrawal include A, increased appetite and blood pressure, B, restlessness and increased blood pressure, C, depression and decreased blood pressure, and D, nausea, confusion, and seizures. So the answer to that one is C, depression and decreased blood pressure. You have one more practice question, that's number 2. Psychological and psychosocial dependence on caffeine has been found with chronic use at what dose? That's 500 milligrams, the number B. All right, thanks. Take a break.